information on children vaccines and what employers are doing and some new mandates that are coming down CDC. And I know we've had a series of these previously and wanted to provide an update as we are now starting to see some changes within the virus that we thought was impactful and meaningful to a lot of you out there. So just a few things here. This is our fourth webinar on COVID-19 vaccines. We will continue to update periodically as there's new information to help you and your organization navigate during these challenging times. A few housekeeping items before we start. During the presentation, attendees' phone lines will be muted. You can ask questions by using the Q&A function at the bottom right of the panel. We will accumulate the questions during the presentation, and we'll certainly do our best to address any relevant questions during the Q&A. And if we are unable to answer them at that time, we'll be sure to follow up with you personally. The link for today's webinar will also be available on our website at www.pbirx.com. I'd say give us a couple days to get that link up and going, but hopefully it'll be up within 24 hours. So many of the attendees here today are either partners or clients of PBIRX who are familiar with our services. For those who are not, PBIRX is an independent pharmacy benefit consulting and auditing firm. We were established in 1993, and we are the first firm to term pharmacy benefit consulting and to provide an independent pharmacy claims auditing product. We have clients nationally and are headquartered in Connecticut with offices in St. Louis, Boston, and Virginia. We are industry-leading advisors in understanding how the pharmacy benefit works and how to best manage pharmacy spend. We also employ cutting-edge technology and proprietary clinical algorithms to help manage drug spend. That being all said, it is truly our specialized people and your accessibility to them who truly identify who we are. So I'd like to introduce two of those specialized people from PBIRX, Dr. Nabil Khan and Dr. Mark Shapiro. Dr. Mark Shapiro is a clinical director of PBIRX and has over 30 years of experience in community pharmacy as both a staff and managing pharmacist. He holds a license to practice pharmacy in 4 states, including Connecticut, New York, New Jersey, and California. Among many distinctions, he is a certified immunizer through the American Pharmacists Association, and he earned his Doctor of Pharmacy degree from the University of Florida. Dr. Nabil Khan is a senior clinical specialist and lead consultant at PBIRX with over 15 years of experience in community pharmacy as both a staff and managing pharmacist, where he continues to maintain an active status. He holds a license to practice pharmacy in Connecticut and New York. Along with many other distinctions, he is a certified immunizer as well through the American Pharmacists Association. He earned his Doctor of Pharmacy degree from the University of Rhode Island. I'm now pleased to turn over the presentation, starting with Dr. Mark Shapiro.
Thank you, Dave. So thank you all for joining us again. And we would like to, well, just one moment. Here we go. So what we're going to do, as Dave had said, we're going to look at COVID. As we know, we're looking at the 4th wave right now, this Delta variant that sort of thrown us askew. So our presentation, we're going to look at updates on CDC guidance. We're going to take a look at some current statistics related to this current wave, or the 4th wave, the Delta wave, variants, obviously the Delta and some others that are on the horizon. Booster shots. There's been talk of potentially giving booster shot studies and the such. What are the possibilities? What's going on internationally with that? We'll also take a look. The vaccines currently are under emergency use authorization, how that does compare to a full FDA approval of the vaccine, and we'll take a deeper dive there. We'll look at vaccine misinformation, what's driving many people to think that there's something wrong with the vaccines or areas of concern. So we'll take a look at that too, as well as vaccine mandates and requirements, also global status and international strategies, and some words on the employer impact, what the employer can do as far as requiring shots from employees. Updates on the CDC guidance. We'll start with masking. So what had happened, we're all aware. I'll just step back a moment. The COVID-19, first identified in Wuhan, China, late 2019, came to the United States sometime early, perhaps late 2019, early 2020, but the first fatality in the United States in February of 2020. By March, it was in all 50 states identified. Vaccines became available in December, and the standard vaccine, we have multiple vaccines now, 3 vaccines. The standard dosing regime, 2 of them are 2-dose, so that's a 21 or 28-day spread between the first dose, the second dose, plus a 14-day post-second vaccine period when we're considered fully inoculated. When we had large numbers of people in May, the CDC said that prior you had to wear masks all the time, that the mask could come off if you were fully inoculated. After May, this Delta variant that we'll get into greater depth started affecting us here and worldwide. And as of July 22nd, the CDC has stepped back and now is recommending that fully vaccinated individuals wear masks indoors and when in areas with substantial and high COVID-19 transmission. As far as schools, and let us not forget, obviously, the kids will be going back to school very shortly. Current recommendation is universal indoor masking, recommended for all teachers, staff, students, and visitors, regardless of their vaccination status. Also recommending layered prevention strategies. That includes screening, testing, ventilation, hand washing, respiratory etiquette, staying home when sick, and disinfecting. And within the schools, recommendation of 3 feet of physical distancing. Concerning travel, and masks are required on public transportation traveling into, within, and out of the U.S. and in U.S. transportation hubs. And where international travelers are required to be fully vaccinated before entering the U.S. or test negative before boarding flights to the U.S. Some statistics on what's going on new cases and vaccination rates. This is the current data. There's almost 90,000 new cases reported daily. This is a 7-day rolling average. The average daily cases in June varied between 12 to 15,000. 7 states are accounting for 50% of all new infections and hospitalizations over the past week. 20% of those cases are in Florida alone. On the right-hand side, we have a map of the states as well as the territories, those boxes in the bottom representing the territories. And the color-coded as far as the transmission that's going on right now, we can see that virtually in the entire country is red, a highly virulent state. Most other states are secondary, that deep orange. And we can see for ourselves up in the Northeast, we're looking rather good, except for New York, which is red there. And the one highlight within the continental United States is the yellow. That's the state of Vermont. And they do have the highest vaccination rates. Fully inoculated, over 65%, I believe 67%. And with at least one inoculation or at least one shot, over 70% of those that are eligible to be vaccinated. So what are the vaccination rates to date? We mentioned that the vaccinations did start in December. Over 350 million doses administered to date. 167 million Americans are now fully vaccinated. That's greater than 50% of the total population, over 61% of adults, and almost 59% of the total eligible population for inoculation. However, there are still 90 million eligible Americans unvaccinated. Our current rolling day 7 average now for vaccinations is 700,000. And let's look back a moment. April was the peak, giving over 3 million doses a day, 3.3 million doses per day. So what's driving this current 4th wave? It's called the Delta variant. And we'll get into in a moment into what variants are. But the Delta variant itself, it was first identified in India in December of 2020 and rapidly spread it worldwide. In the United States, as of May 8th, in the United States again, the Delta was only identified in 1% of new infections nationally. And as of last week, it's identified in over 93% of all new cases. What's special about the Delta? It has increased transmissibility. That means that it is more virulent. And this is due, the COVID is known for its spike proteins. We've seen those classic pictures where we have those spikes on the COVID as a representation, but mutations of those spike protein, that's the Delta variant. It's twice as contagious as previous strains and more contagious than the common cold and flu. It has a higher rate of replication than previous forms of the COVID. And previously vaccinated individuals, if they're exposed to the Delta, they get it, they may transmit it to others, but their infection, their own infection would be for a shorter period. Unvaccinated people remain the greatest concern. Basically, what's happening right now, we're having a pandemic of the unvaccinated. The CDC, this is as of July 26, out of 164 million Americans vaccinated, they reported only 6,600 breakthrough cases. So basically 1 in 25,000. 74% of those breakthrough cases occurred in people over 65. And of the vaccinated people who had a breakthrough case resulting in hospitalization or death, it was under 0.01%. Also, younger people are accounting for more new cases. So this slide here is called the Delta variant relative transmissibility. This gives an idea of the Delta variant and in general the COVID virus, how virulent it is. This is based upon a number and is based upon a value called the reproduction value. And the original COVID strain on the upper left-hand side here, it would have had an R value of 3, meaning one person had the ability to infect 3 people. The new Delta strain in the middle on the top there, they have an R value of 7, the ability to infect one person, 7 other people. To give an idea, chickenpox, which is quite virulent, one person could infect 10 other people. Where does the common cold and flu stand? And it's not on the screen in front of you. They're both under 5. So it gives an idea of the virulence of this current strain. On the bottom are just examples of other conditions. And on the far right, the most virulent one here, the most contagious that we see is the measles. One person can theoretically infect 18 people. So what are mutant strains? And just to go into a little bit about it, viral mutation is a common occurrence that happens with when viruses replicate. There are a lot of mutations. I believe there are 40, if I'm not mistaken, over 40 mutations for the COVID virus identified to date. Most are insignificant. They use genetic sequencing. It's vital to identifying and tracing the variants. And the CDC, they rate, as well as the WHO, the World Health Organization, rates mutants on different types. They have variants of interest and variants of concern. That would be the Delta. That's like a step up. And variants of high consequence. Those are the most of greatest concern. Fortunately, there is no variant of high consequence related currently to the COVID. But the 2 types of variant mutations of significance are those where the virus, it allows the virus to more easily latch onto these cells and become infect more quickly, and also allows the virus to evade any sort of recognition or destruction by the immune system. So as I mentioned, we have the Delta variant. That's a variant of concern. Another variant that's out there is the Gamma variant. That was first detected in Japan and in Brazil. But we've seen little or not, I believe, a little to date in the U.S. And some variants of interest, which are of lower rate that you might have heard about in the news, the Eta, the Iota, if I'm not mistaken, from Peru, and the Kappa. But these are names of different variants that are out there. So at this point, the variants, Nabil, I'd like to hand it over to you. Perhaps you can walk us through and just give a little update to this slide here.
Thanks, Mark, and thank you all for taking the time to join us for an update here again today. As Mark mentioned, the rate of the prevalence of the Delta variant has grown substantially over time. On the left-hand side, we can see every 2 weeks it's been updated due to the ramped-up genomic sequencing of positive cases. And we can see in that orange shade the growing prevalence, that B1617.2. That's the gamma variant, the Delta variant. Mark also mentioned the gamma variant. Currently, it's only accounting for 1.1% of total cases in the U.S., new cases, but that's, as he mentioned, a variant of interest and will be continued to be monitored moving forward. So with booster shots, this has been a topic of conversation, and many people are quite interested when booster shots may be indicated and for who. In fact, there have been reports from the CDC that up to 1 million Americans have received unauthorized booster shots because of wanting to get enhanced protection against the Delta variant and the concerns of waning protection from the vaccines. All three currently available manufacturers of the COVID-19 vaccines have released statements within the past week regarding the effectiveness of their vaccines. Pfizer and Moderna are both in the low 90s in terms of effectiveness after 6 months of being fully vaccinated. Johnson & Johnson did not provide a statistical effective rate. However, they've released data that supports that the immune response is maintained at least 8 months after being vaccinated, as measured by the presence of antibodies and T cells. These are parts of the immune system that aid in the function of preventing sickness of COVID-19. Currently, booster shots are not recommended by the CDC. However, there are reports that they're expected to amend the current emergency use authorization for the 2 mRNA vaccines, Pfizer and Moderna, to allow people with compromised immune systems to get a 3rd dose. So those that have conditions like HIV, liver disease, chronic kidney disease, organ transplant recipients that may take drugs that suppress their immune system. These are all examples of people with compromised immune systems, those with cancer as well. We know that those with compromised immune systems produce a less robust immune response after being vaccinated. So this is a strategy that's expected to be amended to include a booster shot allowable for those populations. Currently, for the general population that have properly or full functioning immune systems, they're not recommended at this time due to the evidence of the effectiveness of the currently available vaccines. The focus really here from a public health perspective has been getting on more people vaccinated. As Mark mentioned, there's about 90 million Americans that are currently eligible for the vaccine that have not been vaccinated. And as a reminder, it's only currently available for anyone aged 12 years or older, with studies ongoing, both from Pfizer and Moderna, evaluating the effectiveness in children as young as 6 months of age. So while that may seem like a very young age to receive a COVID-19 vaccine, it is not coincidentally the same age that they recommend for the annual flu shot, anyone 6 months of age and older. And Mark also previously mentioned it's becoming a pandemic of the unvaccinated. This is evidenced by the current hospitalizations. 97% of people in the U.S. currently hospitalized with COVID-19 are unvaccinated. So this really speaks to the effectiveness of our vaccines, how effective they are in preventing cases, how rare breakthrough cases are, and when breakthrough cases do occur, they really help to minimize the severity of the disease, and as well as being less infectious for those who experience breakthrough cases, they're not as infectious as long as a period as those that are unvaccinated. What's happening around the world? The World Health Organization has called for a pause or a hold or moratorium until the end of September for booster doses. This is in an effort to try to vaccinate other nations that have significantly lower vaccination rates. The goal is, from the World Health Organization's perspective, is to get at least 10% of the population of every country around the world vaccinated first before, recommending or administering a booster shot for those nations that have advanced rates of immunizations. Israel has actually already started administering a booster shot to those age 60 and older. France, Germany, and the United Kingdom have similar plans to administer booster shots to those that are vulnerable, either advanced age, immunocompromised, et cetera. So vaccine misinformation, this is a really hot topic right now. There's been a lot of, sharing of information that is not always rooted in fact or science-based. There's been reports of a quote-unquote dirty dozen, 12 major spreaders of misinformation, amongst others. But these individuals have been traced back to them for posting and sharing of statements or videos that have been reposted and shared in the millions of times. So really spreading far and wide. There have been all sorts of things claimed that are not really based on fact or been proven in terms of these vaccines causing infertility, being made from aborted fetuses, vaccines containing microchips to monitor and track people, and being ineffective. Actually, just earlier today, the CDC released a statement previously for pregnant individuals. They had recommended that pregnant people get vaccinated, and that was just updated to a strong recommendation, based on what they call the V-Safe registry, which is gathered data on 2,500 pregnant women who got at least one dose of the mRNA COVID vaccines, those being Pfizer or Moderna, from either preconception to up to 20 weeks of gestation. And based on the results of the study, the rates of miscarriage were aligned with those that in general, or those that have not been vaccinated or pre-COVID miscarriage rates. So no links to issues during pregnancy or children that are newly born that have been vaccinated while while the mother was pregnant. Some children's blood work has revealed actually antibodies within the newborn, providing some level of protection for those children. So it's been really positive to see the results of real-world data. In terms of the concern around these vaccines being made from aborted fetuses, this is a common concern. Many people who have maybe religious, moral, ethical objections to these vaccines for these reasons. This is a common misconception because these vaccines actually do not require the use of any fetal cell cultures in order to manufacture or produce the vaccine. There have been several organizations, including the U.S. Conference of Catholic Bishops and the pro-life policy organization known as the Charlotte Lozier Institute, echoing similar statements that these vaccines are not found to be ethically controversial, and in fact, they've gone on to say that, quote, these COVID-19 vaccines should be considered an act of love of our neighbor and part of our moral responsibility for the common good. That really speaks to, the true value of getting as many people vaccinated as possible. Not only are you protecting yourself, but those around you that may be unable to become vaccinated. is really a sense of duty and compassion for those amongst us, who may be immunocompromised, who may not be able to produce a robust immune response or become vaccinated themselves. This is really a way for us to help our fellow man and fellow American. There have been claims of these vaccines being ineffective. Just a couple of days ago, a member of Congress from Georgia was suspended, not for the first time, from Twitter for spreading false information of these vaccines not being effective. There was a senator from Kentucky banned from YouTube for spreading misinformation on masking. So a lot of times, people can share their opinions, and we live in a great global kind of culture right now where we can exchange ideas and information. However, there's not always a requirement to substantiate claims or substantiate opinions. So it's really important to evaluate the source of your information. So in general, we like to refer to science-based organizations like the CDC, FDA, National Institute of Health, and World Health Organization versus a social media kind of source of information. Your local and personal health care providers are also trusted sources of information and guidance regarding to health. And, vaccination for COVID-19 and others should be no exception. The federal state medical boards recently also released a statement that physicians who generate or spread misinformation risk disciplinary action, including suspension or up to losing their medical license. So, speaking of trusted individuals, there are consequences for physicians as well for spreading misinformation. So we know these vaccines are currently available through what's called the emergency use authorization, and they have not been fully approved by the FDA. So this is important because there are several implications and considerations that may be fully realized once they're fully approved. Both Pfizer and Moderna have already applied for full FDA approval. And some of the key differences between emergency use authorization versus full approval, just to take a step back, that emergency use authorization was granted and companies producing vaccines, testing, diagnostic testing, many facets related to the pandemic were able to do so because of the global pandemic, because of the known risks, and these aren't typical situations or circumstances, and there is a growing need for a way to mitigate the spread and the devastation caused by COVID-19. For emergency use authorization, the main focus was focusing on the known and potential benefits, and if those outweigh the known and potential risks. So at the time, 2 months of safety and effective efficacy data was required to gain that emergency use authorization. Pfizer was granted the authorization in December, and Moderna a week later. For full approval, more information, more data is required, 6 months of data, and includes additional components. Manufacturers will have to submit a biologic license application, provide additional studies and data related to the safety and effectiveness of these vaccines, formalized labeling process with the manufacturers, provide information in different age groups as well as special populations, pregnancy, lactation, and information related to storage and handling. This is also quite important because vaccine mandates are linked to full approval. If these COVID-19 vaccines receive the full approval, the U.S. military, schools, and other entities can make them mandatory. So this is also a topic of a lot of controversy and conversation. However, just wanted to point out here that schools in all 50 states already require several mandatory vaccinations. These include the measles, mumps, rubella, polio, varicella, also known as chickenpox, and DTaP, diphtheria, tetanus, and pertussis. If any of those diseases sound like something that you haven't heard many people around you, coworkers, family, or friends coming down with, it speaks to the effectiveness of these vaccines and how important it is from a public health perspective to really vaccinate everyone so that those those diseases are not spread and wreaking havoc the way they once did not too long ago. In terms of the armed forces, depending on where they're stationed or located, service members are currently already required to get up to 17 different vaccines. This may be depending on if they're stationed in a location where meningitis is known to be spread within the community or other conditions. Costs are also an important factor here. Currently, during the public health emergency, the ingredient costs of the vaccines themselves are covered by the U.S. government from taxpayer dollars, but only the administration fee of $40 per dose is the responsibility of self-funded employers. Taking a look at what's going around the world in terms of cases and doses of vaccine administered, unfortunately, the same situation exists around the world as we're seeing in the U.S., considerable rise. Recently, we just surpassed in the past week 200 million cases worldwide that are documented. It's expected that the cases and number of deaths are actually quite larger due to many nations having large outbreaks or deaths in remote or rural areas, not always reported or calculated. The number of doses administered worldwide were just under 4.5 billion, which equates to 58 doses per every 100 people worldwide. Most of these doses, however, are part of a 2-dose series, like we have with Moderna and Pfizer here in the U.S., and other parts of the world are using AstraZeneca vaccine, which is also a 2-dose series. So not necessarily 4.5 billion people fully vaccinated, but number of doses, just an important distinction there. We see a big disparity actually between some of the higher income, wealthier nations and lower income nations. Many of the nations that are higher in socioeconomic status have well over 70% of adults receiving at least 1 dose, but many poor nations are still less than 5%. This is markedly so in Africa, where sadly only about 1% of the total population of 1.3 billion people are fully vaccinated. We can see this chart here that's below. It's from the CDC website, and it quantifies the doses administered per 100 people. So we can see Europe and North America really leading the pack, and other continents significantly behind. So as a reminder, what people need to know after being vaccinated, the common side effects are not unique to the COVID-19 vaccines. They're similar to other vaccines like the flu shot and shingles and others that people routinely get. Oftentimes for some, they're more pronounced after the second dose for a 2-dose series. However, comparatively, much less of a concern than actual effects of COVID-19 infection. And we know that the long haulers or the long COVID effects persist in up to 30% of people who had previously been infected. So vaccines remain our greatest tool in preventing further damage COVID-19 has done. Rates of anaphylaxis or life-threatening allergic reactions are extremely rare. CDC report of about 4.5 cases of serious allergic reaction for every 1 million doses administered. So, like with anything else, a vaccine, a drug, anything else, any real decision in life, it comes down to the risk versus benefit, risk of being vaccinated or not being vaccinated, and the benefit. So this is something I encourage, if any of you have not been vaccinated or you know anyone that is looking for information, I would suggest talk to your local, your personal healthcare provider to discuss your own health and your own conditions if you're appropriate candidate for vaccination and if the benefits outweigh the risks. It's important to remember also that the full immune response takes 2 weeks after the final dose. Again, not unique to COVID-19 vaccines. This is the same with flu shots. So if someone gets a flu shot and gets the flu a couple of days later, it's not a sign that the vaccine was ineffective. It just was before the time period required to get that full immune response. Masks and social distancing are still required. Mark mentioned earlier the updated CDC guidance at the end of July regarding those that have been fully vaccinated. It are still recommended to wear masks where areas of transmission are considered substantial or high. And we saw from that map earlier that all states except Vermont are currently in a substantial or high rate of area of transmission. So we're seeing a lot of cities, municipalities, different areas of the nation starting again with either mask mandates or requiring proof of vaccination, like in New York City, to dine indoors or most of the activities that occur indoors, they require proof of vaccination or a negative COVID test. And to encourage those around you that may be unvaccinated, it's important to consider the rate of breakthrough cases. Lately we've seen reports that now, due to the Delta variant, those that have been previously vaccinated can still transmit to others. That's part of the rationale behind updating the mask guidance. So, if someone is thinking, what's the point of being vaccinated if you can still get COVID, you can still spread it to others? It's important to look at the statistics, the numbers behind the recommendations, and that while you still can get COVID and spread it to others, it's significantly reduced in every way if you are vaccinated. It's a way to help yourself and those around you, your neighbors, friends, loved ones, colleagues. It's really a way to do good for yourself and do good for others, and really protect our communities. So we'll change gears now here and take a look at the employer impact. Just want to preface this that I'm not a lawyer. We're not a legal firm. We just are highlighting the major high points, and would encourage you all, if you have further legal questions, to please consult your legal counsel for full guidance. These are just high-level pieces of information that we've gathered. So the Equal Employment Opportunity Commission updated their guidance late May, and some of the biggest pieces of that guidance was that employers can require employees to be vaccinated before physically entering the workplace if there are certain conditions that are met. So if someone's working remotely, as many of us now are, this would not apply. Only before they're actually, physically back at the workplace. Those conditions, we'll get into, but reasonable accommodations is the essence of it. This includes either modified shifts, allowing for personal space and mask mandates for otherwise, or testing if those people are not vaccinated. Incentives may be offered only for those that voluntarily provide documentation of vaccination. Employers cannot, demand to see proof of vaccination based on their guidance and federal laws. Again, all personal health information, not excluding vaccination records, including them, must be kept confidential. This is always of the utmost importance. And again, as a reminder, state and local laws may be more restrictive, and we encourage you to consult your legal team for a more robust and comprehensive guidance. In terms of mandates, equal employment opportunity laws do not prohibit an employer from requiring employees to be vaccinated, again, if they're entering the workplace physically, if they have the reasonable accommodations and provisions of the American with Disabilities Act and Title VII, which accounts for reasons that someone may not wish to be vaccinated, including disability, pregnancy status, or a sincerely held religious belief. And some of the reasonable accommodations are masking, social distancing, modified shift, either staggering shift times or periodic tests for COVID-19. Recently, federal employees, the updated news around that was if they're not fully vaccinated, they would be subject to weekly COVID-19 tests and the opportunity to work remotely. So thanks again for joining us, and we really appreciate you taking your time. We know these were limited in terms of the number of August afternoons we have remaining here as summer is flying by. And I'd like to, Mark, if we have any questions that have trickled in, we'd like to address those, please.
Sure. So again, as Nabil has said, and on behalf of all PBRX, we want to thank you. But I'd just like to touch upon a few points, Nabil. I think would give some elaboration to what was talking about. The FDA approval of the vaccine, does it always take so long? We spoke specifically to this vaccine, but in general, does a full FDA approval of a drug or vaccine take so long?
Actually, in fact, it often takes longer. However, because, the fact that we're still in, the public health emergency and still the pandemic is going at rates that haven't been seen since peak levels last year, this is a priority of the CDC and FDA to try to get these fully approved. So it's occurring much quicker than typically it happens, but not compromising the important safety considerations, not taking any shortcuts there for full approval. But it's just more of a concerted effort across the nation to try to get this fully approved.
Thanks. And another thought. So we're hearing about the booster shot. I believe some people had thought that, we take our 2 shots and that would be it. But can you let us know, what about other vaccines? What are their booster schedules? And if you can just elaborate on that a little.
Sure. Yeah, it's a good point. Some people have voiced concerns of, wondering how effective they may or may not be, if there's a need for a booster, but to put in context with other vaccines, another viral infection, the annual flu shot, is also rapidly mutating, and this is the reason that it's administered on a yearly basis. Other vaccines like tetanus, this is administered every 10 years, so it's not uncommon to see a booster shot required for shingles. After there's a 2-dose series after the first dose, between 2 to 6 months later for the second and final dose. So it's not uncommon for booster shots to be necessary to keep our immune systems, protected and keep us healthy.
So I guess a quick segue to that, is there a limit to booster shots in essence?
Remains to be seen. I'm hoping they last longer than on an annual basis, but as it's a new vaccine and a new disease, the information just continues to be gathered, and time will tell. We trust our scientific processes in place, and that will really guide us and our recommendations, or the CDC recommendations, moving forward.
Thank you. And one last thought, related directly to the Delta variant. Looking at the news, listening to the news, we hear how many young people are impacted by the Delta variant, hospitals filling up. Any comments on that? Why it's so high in the young?
Yeah, absolutely, Mark. I think this is, really, in my opinion, a combination of several factors. One being that anyone under the age of 12 is not eligible yet for a COVID-19 vaccine. So they don't have that protection that's provided by the vaccines. In addition, in May, when guidelines were kind of loosened around masking and congregating and indoor dining and all those types of things, it's really, we came out and from a period of keeping to ourselves and not gathering and keeping our distance to more closer resembling life pre-COVID. So I think that increased gathering and gathering indoors and for longer periods of time, in combination with not being able to be vaccinated for those age groups, have contributed to the rising cases in younger people, in addition to, of course, the Delta variant, which is much more transmissible than previous strains.
Okay. And 1 second, I believe some questions have come in. I'm having a little trouble accessing those. Dave, if you can see those questions, can you please direct them to us?
Yeah, sure. So just kind of off some of the questions that have come in here, and we'll try to stump you guys here. First one is Moderna still only for 18 and older?
In the U.S., yeah, it is still 18 years of age and older.
Okay. One of the questions was, can you be terminated for not receiving the vaccine?
My understanding is no. You may be subjected to routine monitoring or other kind of conditions, but it's not my understanding that you can be terminated for that condition or for that reason.
Okay. Tough questions here. So let's see here. Medical individuals seem to be in a bad position if they have a differing view. Is canceling differing views a good idea?
Canceling different views?
Differing views.
Oh.
So if someone does not agree with the position, I mean, from our perspective, and a lot of these things obviously are being debated, and that's why people are concerned out there because they're getting different types of information. And from my perspective, I think it's important to listen to everybody's views. Because I think that's what allows us to be a great country, is listening to different views and then, being smart about the decisions that you want to make. But anything else you want to add to that?
Yeah, I would agree. I think that's absolutely right. What makes us great as a nation is our diversity, and this is no exception. There are varying perspectives and opinions. However, I think in this kind of scenario, in a global pandemic, it's important to be able to substantiate, not just based on opinion, but also, use like real data to guide or steer opinions and perspectives.
And I would just like to add, it is a gray area as far as opinions, but we do have a strong basis in science. A lot of what has been presented by these professional associations and national associations, CDC, FDA, WHO, it is based in science. Science sometimes isn't 100% correct. We all know that. But it is based on a scientific principle that tries to get to the best truth. So I would just think that's a perspective on it too.
Okay. Is there a specific metric used to determine when a community is so high risk a vaccinated person should wear a mask?
In terms of a specific metric, I don't know of one metric, but I think the rationale is based on rates of transmission, new cases, things like that. But I don't know of one metric that's used to determine high risk, but to my understanding, it's based on number of new cases, and that being the primary reference point.
Okay. Yeah, some tough questions here. If 50% of U.S. residents are vaccinated, where does herd immunity begin as a percentage? What is the percentage goal of immunizations?
That is, it has varied. It is over 70%. I believe right now it's about 75%. It also depends on the virulency of the virus or the infection that we're talking about. And that's why it's become a moving target, both in the beginning as they determined that, and now with this Delta variant, it's moving again.
Okay. What exactly does efficacy mean? Lesser symptoms or protects against the body getting COVID?
So that's a good question because some stats from clinical trials define efficacy in different ways, and their methods during the studies. So some may test only those that are symptomatic for COVID-19 and then base the efficacy rates on that. Some trials or studies may test all people, symptomatic or not, to determine efficacy. Some may use different markers, such as viral load in nostrils of people that have been previously vaccinated, and a cutoff to determine if the vaccine was effective. Others may use rates of death or hospitalization to determine efficacy. So it's one of those things that it depends on what you're looking at and what's defined as effective to determine the efficacy rate.
Okay. So are masks required in all the United States or just some states and counties? If our state mandates masks, is it legal to refuse service?
So if I heard all that correctly, there's a few parts there. So I think in terms of requirements, it depends. You might go in one state and there might be one business that requires masks. There may be a certain office building that requires masks, and it can vary substantially. So I don't think at this point there's any broad mask mandate, but the updated CDC guidance is a recommendation of those areas with substantial or higher risk of transmission, but it's not a mandate to my understanding. It's just a recommendation.
Okay. Is there guidance for employees traveling abroad with regard to testing and post-trip precautions?
I would say the best resource for that is the CDC. They do have travel requirements there. I'm not sure what other federal agencies there would be associated with that, but the CDC would be the best reference point to start looking at that. They do have a travel requirements section.
Yeah, some of the countries around the world, the CDC has issued advice against traveling into based on their current status with COVID-19. But it's important to consider the CDC as well as your own individual status. I know for returning to the U.S., if you travel outside of the U.S., you'll need to provide a negative test within 48 hours in most instances to board a plane to return back to the United States. So, in terms of planning a vacation, that if it ends on Sunday and you're due back at work on Monday, just kind of rolling the dice there to ensure you can get that negative test before you fly back.
Great. And do we know what % of unvaccinated have had COVID?
I don't know if you can quantify that, again, because early on there was not really a lot of testing going on because of the limited availability of tests. And in the early stages especially, it wasn't always differentiated or understood when it might be COVID versus pneumonia or the flu. And even today, those that are either vaccinated or not, sometimes people can chalk it up, if it's mild symptoms, to a common cold or acute bacterial infection until you get a test. it's not really something that you can discern. So because the symptoms are so similar. So if I heard the question correctly, if we can quantify or say what percentage of unvaccinated have had COVID, yeah, that's my long-winded way of saying I don't think so.
Well, let me specify a little bit more. It's not in this part, but I'm just going to ask. And I know that Mark and I we were debating this the other day. Is actually I shared with Mark a recent graph with the recent people in the state of Connecticut who have COVID, and what percentage of those were unvaccinated and what percentage were vaccinated. And I don't know, Mark, if you recall that and have any information on that, kind of what percentage, say, out of 100 people, who have COVID today, how many of them were unvaccinated and how many of them were vaccinated?
We did discuss it. From that particular graph, I do not recall the numbers, though there was a great disparity between those that were unvaccinated and those that were vaccinated. But within our presentation today, we did cite, and this is a figure related to the current Delta variant, up to 97% in that particular study that was cited of currently hospitalized people are unvaccinated. So that gives an idea of the sense of people unvaccinated being infected by the COVID, or I should say more specifically the severity, but it gives a sense of the difference, of the disparity.
All right, so those were the warm-up ones, and I know we only have a couple of minutes here. I'll just try to get maybe just one more in here, this is, what are your thoughts on CDC withdrawing PT-PCR, the diagnostic panel, effective 12/31/2021?
I think we're going to take a pass on that. We can try and research an answer and send it out to everybody, but wouldn't want to give any misinformation.
Okay.
Yeah, that'll take a little...
And I'll just do one more here. Are there actual reliable studies demonstrating the risks versus rewards for childhood masking? They are at extremely low risk, and there are risks for mask wearing on younger children. Few, if any, are properly fitted or worn, and few are N95, so the prophylactic impact of masks is quite low.
Yeah, I think that's more opinion-based because we know that recently, in the last several weeks, the number of cases that are children in the U.S. have grown, quite substantially and not within the proportions previously. So because they're amongst the groups that are still not eligible for vaccination, there's like clinical trial going on to determine the effectiveness, but if we think back to this time last year, our only methods and means of preventing the spread of COVID-19 was masks and social distancing and not gathering in large crowds. In my opinion, children are currently in that kind of stage where we were last year, not being able to be vaccinated. This is our best method to mitigate or slow the spread, and it's it comes at a cost. It's not something that's favorable or desired to have our children met, but in an effort to protect them and keep them out of the hospitals, I think that's quite an effective way to do what we can to protect them at this point.
Well, thank you both. Some tough questions here at the end, but there are certainly a few other questions that we haven't gotten to, and if we haven't responded to your questions with this quick Q&A, we'll be certain to get some answers out to you based on the information that we have. Also, one of the overall questions was, can we send out the presentation here in this deck? As mentioned, there will be a recording of the presentation on www.pbirx.com. If you're interested in some more information, just contact your PBRX account consultant or call us, 203-882-1188. So I appreciate you, Mark, Nabil. Appreciate all the attendees. I know it's summertime in August, but we hope this information was helpful to you. in understanding some of the updates on COVID. As always, we do plan on hosting additional future follow-up webinars to address any rapidly progressing developments about the pandemic. We'll also be presenting some additional industry-relevant information, and we'll send some future WebEx invitations for those discussions. So, be on the lookout for those. We do try to make these meaningful. We understand that your time is valuable, so we want to make sure that we're providing meaningful, impactful information for you. Any additional questions, again, please feel free to reach out to your PBX account consultant or reach us via our phone number. And again, thank you again for your time. Have a great afternoon. Have a great summer. Be safe, and thank you.
Thank you.